everybody. This is iCubed. Welcome to iCubed episode 20. Episode 20. That is fantastic. I am Dr. Alice Lee. This month I welcome back a guest that we've had on here multiple times, my co-educator, Dr. Mark Zosky.
Pleasure to be here, as always.
Dr. Zosky did his emergency medicine residency at LSU Baton Rouge, and this year he has joined me as faculty at the University of Arizona College of Medicine, Phoenix, as an assistant clinical professor. I'm very happy to teach down there with him. Anyway, so this episode I'm going to speak about a recently common problem, it seems like, because I had 2 cases within 2 weeks of patients with a tracheal decannulation, i.e., oops, my trach fell out.
Oops, the trach fell out. Can you just put it back in, and then we'll send them back to the sniff? Oh, sure, easy.
That's essentially what most of us think, right? I mean, you get a pre-hospital call, the trach's fallen out, they can't get it back in. They send the patient in for you to put the trach back in. So let's talk about my case number 1. You get the pre-hospital call, right? So he's a 57-year-old guy with diabetes, alcoholism, meth abuse, and he's chronically trached. Well, he pulled out his trach and apparently has a history of doing the same. The staff and the medics couldn't get the trach back in, so the medics were able to get a ET tube size 5 into the trach and are en route now to you. They say that his saturations are okay. He's tachycardic though, his heart rate's in the 140s. So he gets to your ER and you take a quick look at the patient. He's a heavyset male, he's pretty restless. He's awake, but he's not really responding to you. He's kind of bug-eyed actually, if I recall. He's definitely in respiratory distress. You look at his neck and ENT area, his mouth is small, he's got a very big tongue. His stoma is small, but there's no bleeding and there's an ET tube in it. The vital signs are temps 39.1, blood pressure is 116/72, his heart rate is 144, his respirations are 39.
Alice, this case just keeps getting worse and worse as I look through your slides. I'm serious, because it started off, hey, we got a guy chronically trached, and in my mind, like, oh, that's good. This is not a fresh stoma,
right.
It's not a fresh surgery. The track should be nice and mature.
Right.
I mean, you should throw a garden hose through that. This is easy. And then you know that he's tachycardic, and then you know all they can get is a small 5/0 tube in, and now he's, well, I forget the last slide, but he's essentially very altered and somnolent. Now I look at the vitals, and he's febrile, he's extremely tachycardic, he's extremely tachypnic, and he's in respiratory failure. And
yes, right.
The nurses told me to come in this room, and I walk in, and I just want to walk right back out. I can't continue of how much these cases are frustrating.
Right.
And even then, too, it's like, so we have a patient that can't give history.
Right.
Paramedics probably don't know much about him other than the patient was very sick and needed to go to the ER and have this problem dealt with. But we have to make split-second decisions of, why was the trach put in?
Yep.
When was it put in?
Right.
Is there a reason we can't intubate from above? Did he have tongue cancer, throat cancer?
Those are fantastic thoughts, actually. So let's proceed at this point.
Here we go.
So we go back to the vitals. He is febrile, like you said. He's tachycardic. His SATs, though, fortunately, is 95%. And that's through the back valve mask, through the ET tube in the stoma that the medics had put in. So my thoughts on this case, well, simple trach replacement, just like you thought. I was like, okay, I'm standing in the bedside. Let's just get the respiratory nearby, and we'll get the ET tube, which was probably a 7, shyly 7. It looked like that size anyway to me. So I take the trach out, and boy, was I wrong.
Oh, God, here we go.
Are you getting nervous?
These things make me so nervous because they're always fine until they're not.
Yeah, exactly. So I'm just going to tell you what happened because it was quite the case, okay? So I thought, like I said, it would be just a really easy trach exchange. I first tried a number 6 Charlie because it's smaller than the 7, figured it would fit right in. Did not fit.
So you're just meeting resistance?
Yep.
And then you don't want to push crazy hard to damage the neck and the surrounding structures.
Yes,
okay.
right. So I tried the 6, it doesn't go in. And then I realized his tube was an uncuffed tube. So I thought, okay, maybe the cuff on the 6 was obstructing the replacement. So decided to try a few other sizes. The respiratory tech brought me the 5. I couldn't get the 5 in. It's still cuffed 5. So I'm calling for an uncuffed tube. We have no uncuffed tube in the entire hospital. So I'm getting a little frustrated by now. My respiratory tech is kind of trying to get what I need. So eventually I just said, well, I got to intubate this guy from above, right? Even though he's satting okay, I can't get a tube in. We don't have the right equipment, so I intubate him from above. He's satting fine. I get him intubated. I leave the bedside. I get called back stat because they do a bedside x-ray, and guess what? Ta-da! You know how they say you shouldn't be diagnosing a tension pneumothorax on x-ray?
I do it all the time.
I'm glad I'm not the only one.
It's huge.
It's giant, right? It's gigantic. Mm-hmm. Fortunately, he was actually satting fine the whole thing.
And this is after he's intubated, you
said,
right?
This is after I intubated him orally from above.
So we are blowing positive pressure into this. Super.
Yes. So we're making this tension even worse, okay? Anyway, fortunately, he was someone who can do, I was able to do a chest tube pretty easily on. He was unconscious and intubated. So I put a chest tube in. Everything seems copacetic at that point. And then the radiologist calls me and he goes, the CT of the neck and chest shows that there's a stenosis at the level of T1. The lumen of the trachea is 3 millimeters, and it's about 2 to 3 centimeters below the cords.
I wouldn't have thought that was compatible with life.
Yeah. Here's a CT scan. I'll show you exactly what he saw, and it's actually pretty amazing. So we can follow the tube.
The AT tube.
We can see that the AT tube is that hard, round, white circle. And we just follow it, and we follow it down a little bit, and we follow it a little bit more, and we go down to where there's...
And there the end of the ET tube is,
yep.
And there's some very tiny calibers. 2.75 millimeters.
Yeah, that's the trachea.
That seems small.
Yeah. So that's the tip of the the endotracheal tube, because past that, there's no tube, it's just the trachea. So the radiologist calls me with that report. I'm thinking to myself, well, it makes sense because it was difficult for me to pass the tube all the way down. Okay. So
what size tube did you put down again?
Just a 7.
So I'm surprised you were able to get a 7 in.
Well, I was able to get the tip of the tube was just stopped right where the stenosis was. So he was stable, but because it was such a complicated case, I called transfer center and convinced them to please accept a transfer for ENT. We don't have ENT. So anyway, so that was quite the challenge. Tension pneumothorax and a stenosed trachea.
All you had to do was replace the trach and they could have gone home. That's all we needed to do.
Next case, I had another case 2 weeks later.
Oh goody.
So this one is another 57-year-old male with diabetes, depression, and anxiety. He was chronically trached. And what is up with 57-year-old guys with diabetes and trachs? His trach came out for unknown reasons. The paramedics found him with the trach partially in place. All they did was just keep it in place en route. Unfortunately, en route, the patient increasingly became more and more distressed. On exam, he's heavy-set, obese male. He's visibly in severe distress and just really labored. He's pale, he's ashen, he's unresponsive. Neck exam, the stoma is small. There are soft tissue tags I've noticed on this patient on the edge of the stoma, but there's no bleeding. Vital signs on him was blood pressure 198 over 112, heart is 113. His respirations are 30. His saturation is 78% on 15 liters non-rebreather.
Toxic trach patients are just following you.
Yeah, so my thoughts on this guy was, okay, because of my trach patient 2 weeks before this one, I thought, I'm not going to fiddle with the trach, right? I'm just going to intubate from above because he's hypoxic. This is much more urgent than the other patient. So I was able to intubate him with a 7.5 using the glide scope, but the tube would not pass the cords except just beyond the cords. The balloon inflated, and I can see the balloon balloon, the top of the balloon just past the cords. But he was saturating better. I put him on a vent. His sats improved. I breathed a sigh of relief and I left the room. But I get called back pretty much a few minutes later because now his sats are dropping. The radiologist called and said that the endotracheal tube is now in the piriform sinus. So probably as they were taping the tube down, moving the patient, because the tube was just beyond the cords, it probably popped out and just landed in the piriform. Yep, exactly. So now he's hypoxic, he's in distress again. I got to re-intubate guy, but this time I can't get it past the cords at all. It just, the balloon is sitting at the cords. So I'm trying this and that. I even tried putting a bougie down. I couldn't get the bougie down past a certain point in the trachea because I can feel it just get stuck. I tried a guide wire. I went the guide wire down. I put the tube over the guide wire. I could not get the tube past the balloon past the vocal cords, right? He's sort of saturating okay at this point. I'm kind of out of options with trying to intubate him orally from above, using a bougie, using a wire.
Go back to the neck now if you can't do above, huh? Right,
but trying the bougie through the neck hole, it would not go down. Try the wire through the tracheostomy, it would not go down.
Yeah, and the bougie's pretty darn tiny too.
Yeah. So at this point, I call pulmonary. So the Dr. Anthony, she came over with the fiber optic scope, and she tried to bronch the the ostomy, and she tried to bronch the from above as well, and she could not get the scope even past
distal to the vocal cords.
Right.
Oh my God.
Right. So she looks in there, and you can see that there's stenosis just below where the stoma is. She tried to put just a trach at the end of the fiber optic scope to try to get that down. We overhead stat call to general surgery on call. So we get 2 surgeons come to the room, and one of them, our interim surgery department chair, he's a big guy. He stands over the patient. He grabs a tracheostomy, a Shiley that we had at the bedside, and he just kind of just shoves it in there. And you can hear this little crack.
Listen, they have every right to do that because they know how to fix it if something happens. So he was able to get it?
Well, he got it deeper than what we were able to do. Okay, so there was still a couple of centimeters from the flange of the trach above the skin. Okay. But at that point, it was already decided. The general surgeon had already decided we're taking this guy to the OR. Sure. So he took the patient off to the OR and placed another trach into this patient.
Wow.
At one point in this patient, there were like 5 doctors at the bedside. There was myself, another ER doctor, there was the pulmonologist, and then 2 surgeons who came by.
I mean, these cases you feel so impotent because we all have our algorithm. It's like, you don't want to mess with the trach. Easy, everyone knows, intubate from above. Okay, we all know how to intubate.
Yep.
We all know how to do a hard airway. You have glide scope, bougies, all these backup things. All right, that's failing now. Okay, approach the neck. Okay, that's not working either. That is just a scary case.
That is a scary. Both of these were
very scary cases.
They were both very enlightening cases for me, and fortunately they turned out fine. Actually, as it turns out, they both left the hospital a while later, intact apparently, or neurologically intact.
My scary bleeding trach patient story was when I was an ICU resident. I think it was like my first month in the ICU, so I had no idea what I was doing, and I was terrified. Yeah. A general surgeon told us that we need to come see her patient on the floor because they were moving her to the ICU to be intubated. Fast forward a week later where she ended up needing a trach, okay?
Yeah.
And I'm the one on nights.
Okay.
Problem solved, she got a trach, everything's going fine, yay, you kind of forget about her, you know. And then the nurse calls, oh, she just had her trach done a few days ago and she's bleeding. And I'm like, oh no, and it's like 3 a.m.
Right.
And what do we do? Yeah. Well, did you call surgery? Did you call surgery yet? Yeah, they're not in-house, or they told us to call you because, we were 24/7 in the unit. Like, okay, I'll come take a look at her.
Yeah. Wait, you were intern, or what were you?
I was second year.
Second year, okay.
I had no idea what I was doing. So I go to the bedside, and she's hypoxic. They're bagging her, and I'm like, okay, step 1, deep suction her.
Right.
That doesn't help.
Yeah.
Try to bag through an obstruction.
Yeah.
That doesn't help. And
right.
she's just staring at us.
Aww.
And we took the inner cannula out and tried bagging, still hypoxic.
Yeah.
So at this point, I call my attending, who I've never met before, and he was just on. I was like, "Hi, it's Mark Zosky. It's 3 a.m, and it's very nice to meet you. By the way, I'm sorry I woke you up, sir." And I basically give him the rundown of the patient very quickly, and he goes, "Did you try suctioning?" "Yes, sir. It didn't work."
Yeah.
"Did you bag her?" "Oh, it's very difficult to bag, and we couldn't do it." "What are her stats?" He goes, "Oh, well, easy, just intubate from above." And I said, "Well, about that, the reason she has a trach, sir, is because her cords are the size of, Texas, and nothing is going through there."
Yeah.
And I just remember staring at her and, just feeling so helpless. And she was just hypoxic and gray and turning blue. And I don't know what happened, just sheer luck. I think while we were bagging her, we punched through some blood clot or mucus plug or something, and then her sats came up. But I remember just looking at this lady while she had blood around the side, hypoxia, and I'm just going.
So you
and I forever knew. I was like, I hate trachs.
Yeah. So, didn't you try suctioning through the trach already at that point?
It didn't work, or maybe. So what I think happened, she has a big, because it was relatively fresh, like post-op day 2 or 3.
Yeah.
I wonder if she had just because the nurse had noted some slow oozing bleeding throughout the day, but nothing where hemodynamically or she was compromised, sats were compromised. Yeah. So I wonder if she just had big old blood clots that were just kind of obstructed the pathogen, but we just bagged through with just positive pressure, just went poof and pushed something out of the way, and then we could bag her easily and her sats went up. But
that's scary. All right. So we are going to talk about learning focus number 1, which will be on trach decannulations. I was in touch with Dr. Justin Morgenstern, who just fortuitously just posted his last post on the 25th of July, and he graciously allowed me to use his post as sort of a guide to this first learning focus. I like the way he thinks through what to do with a patient that has a trach, who has respiratory distress. He based his thinking and his approach on this algorithm that was published back in 2015 by the National Tracheostomy Safety Project, which is put out in England, actually. So Justin Morgenstern's approach to the trach patient in respiratory distress: 8 steps to think through. 1, call for help. Number 2, think about the oxygenation of the patient. Number 3, remove the inner cannula.
Oh yeah, that's a big one, because that one can just easily get occluded and you take that out and they're fine.
Yep, exactly. Number 4 will be using a suction catheter to help. And then number 5, remove the tracheostomy itself. Well, both of our cases started here, right? The trach is out. Number 6, intubate orally. Number 7, ventilate the stoma. And number 8, intubate the stoma. Number 1, call for help. Well, this is self-evident, obviously. You get an RT at the bedside. He suggests trying to get ENT or someone who can use fiber optic scope, and then having your difficult airway card. Well, at my community hospital, I don't have ENT. We do have a fiber optic scope in the ER. I am not facile with it, but the pulmonologists are. So we have pulmonology in-house. Second thing to think about is the oxygenation of the patient. So first thing he recommends, applying oxygen to the trach and to the face while you're trying to figure out whether the patient had a total laryngectomy or just a simple trach. Because it's, obvious, if you have a total laryngectomy for, let's say, laryngeal cancer, there's no connection from your mouth to your trachea, right? The distinction between having a total laryngectomy versus just a simple trach is critical, obviously. It determines where you're going to oxygenate the patient. He recommends using continuous capnography in the nose, actually, to distinguish whether or not you've got a total laryngectomy, if you have the time to do that anyway. If you have a patient with just a trach, you can apply oxygen to the face and the trach. If you have a patient that has a total laryngectomy, obviously you can only apply oxygen to the trach. Number 3 step he recommends is to remove the inner cannula, which you astutely talked about, which is if the inner cannula is obstructed with a mucus plug or blood or whatnot, phlegm, removing the inner cannula very quickly relieves the respiratory distress. Number 4, now if number 3 doesn't work, number 4, use a suction catheter to pass it down through the trach. If it passes, then there isn't really no obstruction, only a partial obstruction in the trachea. Tracheostomy. Number 5, if none of the steps you've already done kind of did not help, you just have to take a trach out basically. But don't forget to deflate the balloon if it's a cuffed trach. Both of my cases starts from here, where the trach was involuntarily or voluntarily taken out. Step number 6, if the trach is out, then you got to think about intubating the patient. If the patient is not a laryngectomy patient, you can intubate the patient, or you can ventilate the patient from above using an upper airway device such as an LMA or a BMV or a tube, endotracheal tube. Number 7 step to think about is to ventilate the stoma. You can use a pediatric BVM or size 2 LMA over the stoma to help ventilate the patient. And then number 8, last step would be just to go ahead and intubate the stoma. Easier said than done, as my 2 cases demonstrated. If you're not able to intubate through the stoma, he suggests using a bougie, like I did try, into the stoma, and then intubating by advancing the ET tube over it. Use an ET tube that's smaller than the trach that was in there originally, so that makes sense. Right.
Can I add one focus to the back part of that?
Yeah.
I was so nervous because I was a baby resident doing this for the first time in my case, that I got the bougie in, I hubbed a tube over, and I was so excited.
Yeah.
We got the tube over that, well, I just made it super deep.
Yeah.
I main stemmed it. And then everyone's looking at me because I was high-fiving.
Right.
Like, doctor, he's very hypoxic. And I said, but I put the tube in. And they're like, why is so much of it in? Oh, oops. And I went back to that, and he was fine.
It was fine. Okay.
But I was very nervous, and I just whooshed.
Yeah, exactly. So we do that often with pediatric intubations, right? You're just so nervous and so excited that you finally get the tube in, or you're able to get the tube in. Yeah, for sure. All right, so learning focus number 2. This is something brand new for me that I learned through this spring screencast, and it's actually very critical information. Tracheal innominate fistula. Have you heard of that?
Oh, it's terrible.
This is the worst possible complication of a trach patient. I listened to Scott Weingart's podcast at Emergency Medicine Cases with Anton Hellman.
Yeah, this is like the scariest thing I think about with trachs. It's just...
I've never had to take care of one, and it wasn't even in my intellectual horizon, because when I read about this, it really made me nervous. I was fortunate I didn't have to deal with this, because I didn't really know what to do about this until I learned about it. So Scott Weingart, he had a patient early in his intensivist, I guess, career, where it was a tracheal innominate fistula that bled out and exsanguinated through his trachea. But anyway, let's talk about the anatomy just a little bit. So the trachea, as you see in this diagram, has a balloon just behind the innominate artery, which comes out of the aorta, and it's just behind the sternum and in front of the tracheal balloon. So what happens is that the balloon can erode into the innominate artery, right? Isn't that horrible? So Scott says that the bleed or hemorrhage from the tracheal innominate fistula can happen, or most commonly happens 1 to 3 weeks out from the surgery. There's usually a little sentinel bleed, which commonly heralds the exsanguination. However, it's hard to diagnose the fistula. Tracheal bleeding has a pretty wide differential, though. Most things on the differential is not not the tracheal innominate fistula. He says most tracheal bleeds should have ENT involved at some point in his hospitalization. And he says most of the differentials are really not during this time course. So if you have any kind of bleeding from the trach between 1 and 3 weeks, you really have to put as number 1 as your differential, the tracheal innominate fistula bleeding. So then what do? Well, he says that if there is an enormous amount of bleeding in front of you, you intubate from above, you overinflate the balloon, you take the trach out so that you can intubate with an ET tube going past the stoma itself. And then you literally put your finger through the hole and you hold, you pinch the innominate artery against the back of the sternum, and you keep your finger there until you go to the OR, all the way to the OR. This was a shock to me, but it makes total anatomic sense, doesn't it? Mm-hmm. But oh my gosh, would be like so nerve-wracking to have to do this. Okay.
Good cases.
So that's it, yeah. I hope you learned something. Did you learn something?
Well, I learned the next, trach patient in extremis. Dr. Alice Lee can see that, and I'll hang down the back and drink coffee because you're the expert.
Thank you again, Dr. Zosky, very much for joining me. Now, everybody, I hope you're going to ACEP. If you're going to ACEP, come by the EMN booth because there will be a live recording session at the Emergency Medicine News booth featuring me. It'll be October 2nd on Tuesday, October 2nd at the ACEP San Diego conference. So please come by. And I promise I don't bite, just say hi, okay? So thank you again for listening this month. I hope to see you. Bye.
Bye-bye.